in terms of oxygen toxicity, my point is that, to think of oxygen as a drug, because it has its toxic side effects. So if you were on a greater than 50% for more than 24 hours, your lungs could be rendered oxygen toxic. What does that mean? Primarily what that means is that your lungs become stiff. They have some fibrotic changes in them. Does that mean that you don't give high levels of oxygen if the patient needs it? No, you still have to give it, but you just have to be aware of the fact that they will have these changes, or most likely will have these changes accordingly. And so that you're always working to bring down the oxygen level as soon as possible, as soon as the patient can best tolerate it. Okay. And in terms of looking at oxygen toxicity, there could be some refractory hypoxemia because of the fibrotic changes accordingly. And then the other symptoms that you see listed on the slide are basically as a result of the changes in terms of the tissue. The tissue changes accordingly. Those two sets we talk about on the slide, PEEP and CPAP. PEEP is positive end expiratory pressure, and CPAP is continuous positive airway pressure. And what they basically do is they help to keep the alveolus distended, so that if you do have to give high levels of oxygen, it works so that you can give lower levels of oxygen, because you're keeping the alveolus distended so that it can get more oxygen. But the point is that if you have to give higher levels, the alveoli can handle it under those settings. Now, in terms of hypoxemia is what's in the blood. Hypoxia is what affects the cells. And there's basically about 5 different reasons why the cells can become hypoxic. Okay. The first is that they don't have to come in this order, but this is the first one we'll talk about. And that's hypoxemic hypoxia. Hypoxemic hypoxia means that you have a low PaO2, so that your source of oxygen is very low. All right, and your source of oxygen is low. Subsequently, resulting from poor nutrition or disease entities that could also impede the amount of oxygen that's ultimately getting into the blood. So hypoxemic hypoxia, the lab finding that will put you into that direction, that's the cause, is a low PaO2. So you're not getting enough of the source. Circulatory hypoxia basically results from the fact that you're not pumping the blood around adequately. You're not pumping the blood around so that the cell can adequately get the oxygen. So if you have cardiac failure, or you're hypotensive, or you don't have enough volume, which would cause you to be hypotensive accordingly. So here, the issue is that you're not pumping the blood around adequately in order for the cells to get oxygen. Okay. Now, the end is that it is in a sense that you're in a hypermetabolic state, so that the cells are not using up the energy that's being produced by aerobic respiration, so that you need more. I still think is running, because I still think NYPD also has access to that as well. I'm not 100% certain, but anyway, but definitely Jacobi and Cornell. Now, in terms of blood gases and what values you're going to look at, people suffering from histotoxic hypoxia may have a normal PaO2. So people suffering from histotoxic hypoxia may have a normal PaO2, a normal supply, a normal amount in their blood. What the problem is going to be their saturation, because instead of oxygen hooking up to the hemoglobin, what ends up happening is carbon monoxide or something else like cyanide hooks up to the hemoglobin and goes to the cell. And so basically you're looking at the oxygen saturation. And on the blood gas, you know, most blood gas machines don't do this anymore. There used to be a calculated blood gas and a measured blood gas. Most blood gas machines now in the past 10 years have, you know, they will only give you a measured or a co-oximeter blood gas saturation, so that it's directly measured. Okay, so you know, this is the patient where pulse oximetry will not work because it'll see something on the hemoglobin, but it doesn't know whether it's oxygen or not. That's why the blood gas is so important on the initial intake. So what's going to happen to the patient when they're suffering from hypoxia? What are you going to see with them? Well, respiratory-wise, the cells want more oxygen, so you're going to you're going to increase your ventilation. You're going to be tachypneic. Remember, tachypneic is an increase in rate. Hyperventilation is not only an increase in rate, but an increase in volume. Okay, so tachypnea, an increased rate to the same tidal volume. The patient could become dyspneic, and like I said, they could hyperventilate. Cardiovascular, they're going to get tachycardic because the body's going to try to pump that oxygen to the cell. Cardiac muscle gets, cardiac tissue doesn't get enough oxygen. You may start to see problems with the conduction system, and you'll see dysrhythmias. Pulse changes may become more thready. Initially, they could become hypertensive, and then ultimately not sustain the hypertension and become hypotensive. From a hematologic standpoint, you're looking at anemia in the sense that you don't have enough hemoglobin to carry the cells around. Polycythemia, it could be that you don't have the appropriate cells to carry the blood around. Neuro, remember that brain tissue, nervous tissue requires two things. It requires oxygen and it requires glucose. And if you don't have oxygen and glucose, your nervous tissue, your brain is not going to work. Okay? And it has to be glucose and it has to be oxygen. The brain does not survive by anaerobic respiration. It only survives by aerobic respiration. Okay, so you need oxygen and you need glucose so that the patient may become disoriented, restless, you know, and later on suffer from lethargy. You could also see central cyanosis, going back to the mucous membranes, as well as digital clubbing. I mentioned that when you're measuring oxygen, there's two ways you can measure it. You can measure it by your PaO2, which is your how much oxygen is in the blood, and you can measure it by your saturation, which is the percentage of hemoglobin that have oxygen. Pulse oximetry is a non-invasive way of measuring oxygen. We talked about pulse oximetry before. We talked about waveforms. And then in terms of looking at the measurement, you know, in terms of on the finger accordingly. You always want to make sure that you have good capillary refill in terms of putting the, you know, where you put the probe. And you also want to make sure that the probe is designated for that area. Sometimes you'll see, and incorrectly, you'll see that they'll take the pulse ox indicator and the disposable one, and they'll, with the adhesive, and they may place it on the forehead. That that type of probe is not meant to be put on the forehead. So you have to make sure that you use the right probe for the right, you know, the right, you know, monitoring. And in terms of, sorry, in terms of when you need to give oxygen, well, if your PaO2 is low, your saturation is low, where hypoxemia may be suspected, and okay, where hypoxemia may be expected, some trauma with your initial acute MI, short-term, post-operatively. Contraindications, you have to consider that, people who have COPD, who have a PaO2 of greater than 60, you don't necessarily want to supplement oxygen, because remember, now they've moved from CO2 to oxygen as a source of, stimulating the process of ventilation, the process of breathing, so that if excuse me, if you put the O2 too high, you'll base the body will say, oh, I don't need to breathe anymore, so they'll respiratory arrest. You have to remember about oxygen toxicity. There's certain chemotherapeutic agents, specifically bleomycin, that you have to be cautious with it because of its action on the hemoglobin and etc. And then, as you well know, oxygen is a fire, it can have problems in terms of fire hazard. It's in my lifetime, smoking was allowed in the hospital. You saw smoking in the nurse's station, smoking in the doctor's station, and even patients smoked as long as there wasn't oxygen in the room. Now, every hospital in the country and in its territories, and I'm sure in the world, is smoke-free. So, you don't see that as an issue anymore. FiO2 stands for fractured inspired oxygen, and that you're looking at what percentage that goes along with it. And then we talked about oxygen toxicity. I just mentioned to you about oxygen and it's on patients that are the hardest to deal with that concept of the patients who have behavioral issues, and smoking is a source of, in a sense of a source of support, an inappropriate source, but a source of support for them, and that needs to be dealt with accordingly. Now, in terms of delivery systems, all types of delivery systems, there's a low delivery system, and then there's also actually high flow systems. Now, we'll go over these devices. First of all, what you see in front of you is a flow meter. And a flow meter, the universal color for oxygen is green. So when you're looking at wall outlets, the universal color for oxygen is green. Black is air, white is suction, okay? And then when you're looking at down here, you're looking at the humidifier. And anytime you're looking at humidification of oxygen, you're always using sterile water. Never use saline, because what's going to happen is that after the fluid part of it dissipates, you're going to have these particles, which is another problem. So you always use sterile water, and always remember to, if humidification accumulates and water accumulates, you're always going to pour it off the system. You never pour it back into the system, meaning that you never always pour. And in terms of liter flow, you know, you see the ball, the silver ball or whatever it is, color it is, you're going to see the numbers, you know, allocated as to what that liter flow is. The first way you can give oxygen is you can give oxygen through a nasal cannula. And the nasal cannula can provide up to 45%, up to 6 liters. And the reservoir that the nasal cannula is using is the patient's nose. Okay, so if somebody is a mouth breather, you can't really effectively use a nasal cannula. All right, so somebody's a mouth breather, you can't use a nasal cannula. All right, now remember that with 2 liters, after 2 liters of flow on the nasal cannula, you have to use humidification, or else, excuse me, you have to, I just saw something on, sorry, you have to use humidification. So after 2 liters, you have to use humidification, or else you're going to dry out the mucous membranes in the nares. Okay. And the other thing to remember, yeah.
Question.
Go
for
ahead.
the humidification, that is sterile water as well.
Any humidification that you're administering respiratory wise. So not just for the nasal cannula, for anything. You have to, on the ventilator, you have to use sterile water, because saline will just muck up on the ventilator, will just mess up the mechanics of the machine. And with the you know, oxygen therapy that's external, as we're going to talk right now, it's gonna cause problems in terms of you know, dropping off into the airway accordingly and causing irritation.
Okay.
So whenever
Thank
you're
you.
talking about humidification for you know, for respiratory care, it's always sterile water. Only in rare instances, maybe with nebulizer treatments of a very special nature, might you see saline used. But it's always sterile water. Okay.
Thank you.
No problem. Thank you too. Okay. So you know, in terms of what the exact, you know, in terms of how you're writing your note, or you're assuming, you know, how much oxygen the person is getting, you're always writing it for liter flow. It's an approximation how much oxygen the patient is actually getting. So generally speaking, the percentage of oxygen increases by liter flow by 2 to 4%. So obviously that's not an exact amount. So you're going to write down what the liter flow is. Then, as I mentioned to you, that once you go above 2 liters, you have to humidify it. And going above 6 liters, you need to go to another method. Now, a simple mask is something that you're not going to see in the hospital except in the emergency room. Basically, a simple mask is used on the bus, that's what they call an ambulance, sorry, on the bus, on an ambulance, sorry. And a simple mask can generally provide anywhere from 30 to 60%, between 5 and 10 liters, which is, you know, it's not, once again, an exact amount. So it's a quick access in terms of oxygen support, but it's not, once again, an exact, and it's used primarily in those transport emergency settings. Now, what you're going to see in the hospital is going to be this Ventura mask. The Ventura mask is going to give you anywhere from 24 to 50% oxygen, and it takes air from the environment, and it also brings in the oxygen support as well. And you'll see down here, can you see that I'm pointing this out? Each one of those nozzles goes on the bottom here, and you see the blue color thing in the oxygen corrugated tubing. Each one of these has a different amount of percentage of oxygen that you're going to see with a different liter flow. Okay, so I don't remember off the top of my head. I always have to look at it. But let's say 6 liters is going to give you 24%. Okay, but it'll tell you on the bottom. You see where the port is? Well, right here on that round section right here, it'll say how many liter flows, and you'll just turn the liter flow up to what it says. So if it says 6 liters, you turn it up to 6 liters, and it'll give you that percentage. And you need humidification. Now, aerosol masks, I'm sorry, I have to, my friend is calling me about Elmhurst. Anyway, so basically, I just have to answer this, and I just have to tell her.
No problem.
Sorry. The state ed department put out guidelines as to like what the deal is, and I'll send them to you. I'll send them to you guys in an email in terms of what to consider, because one of my colleagues asked me, and I'm getting offline here, but had asked me about liability, and what I remembered in other situations is that there's an expansion of the Good Samaritan Act, and you guys know what the Good Samaritan Act is, right? It's like when you go in and you treat someone, and if there's a sequelae to that it was a benefit that you treated them, you're not going to be held liable for the sequelae. So but there's more stuff written about about licensure and stuff like that. So but I'll send that to you. Okay. When we get off. Now, in terms of this, you're going to see with these masks, you can see when I got this arrow, right? You can see that. Attached to this is going to be corrugated tubing that goes to humidification. Now, the difference here is that, okay, I thought I had it. The difference here is that unlike the Venturi mask and unlike the nasal cannula, okay, where you're going to have to put in a set amount of liter flow, with this type of aerosol mask that's going to have high humidity, you're going to take the liter flow and you're going to turn it up to the highest point on that liter flow to 15. And there's going to be a dial on top of the humidifier, which is going to tell you the percentage, okay? With these type of devices, I'll go over them in a second. Even though it may say on that dial that you're given 100%, because of these holes here in the mask, all right, the highest you can ever give is really about 70%, okay? So even though it may say 100% on the dial, if you actually measured it, it's about 70%. So this is the face tent. So if somebody feels too confined with a face mask, you can use a face tent. So this is where the chin goes, and then the oxygen would go. It doesn't contain the oxygen as tightly, okay, but it's still a method of supplementation. This is the face mask that I'm sure you're most you've seen most commonly. Here is the trach collar that goes over the tracheostomy tube. Excuse me. And this is the T piece. This goes straight on the tracheostomy rather. And, you know, and delivers the oxygen most directly. This is kind of doesn't have a lot of flexibility to it, or it could be the ET tube, this one as well. But this one is only for the tracheostomy tube. Now, before you intubate somebody, the highest, you know, the highest amount of oxygen that you can deliver via a face mask is what we call a non-rebreather. And when you turn it up to that high level, that 15 liters on the liter flow, and you hook up straight to the, you know, to the humidifier to the patient, and basically you get about 85% oxygen. So it's a very high liter flow that the patient, you know, percentage that the patient will be getting. So what basically, I couldn't find a picture, but on here, right, see where the arrow is going back and forth? There's a disc inside. It's a beige disc. You take a breath up, you get all the oxygen from, oh boy. Okay. You get all the oxygen from the back, all right? And when you exhale, you push the disc down, and then these holes that you see in the mask, in a sense, aren't as big. They just have they're a bunch of tiny holes, and you're blowing out the CO2, so you're not losing the oxygen. So a non-rebreather is really, I like to say, is a transitional mask. Either the patient's going to get better or they're going to get intubated. All right. The only time somebody keeps this mask on for an extended period of time is more or less like in hospice, you know, because you want them to feel comfortable, because you know, that sense of cells in the hypoxia is obviously quite uncomfortable. So in terms of looking at the non-rebreather, gives you lead flow, a venti mask accordingly, and nasal cannula. This is just a guide. Home oxygen, you know, there are portable devices. Humidification must be provided, and there's all different methods now that that can be utilized. Your incentive spirometer, this is the one common incentive spirometer that's used. This is a guide. Here, the yellow thing, you're going to, and basically how this operates, and most places where there is no elective surgery now, but most places where, you know, you have, you know, surgery will have pre-surgical classes on utilization of an incentive spirometer. So that's the idea of, you know, taking a deep breath in so that you're filling up the alveoli. So, so there you go. So incentive spirometer is just for you to take a deep breath in, and the indicator is so that the person knows how well they're doing. Patients should be encouraged to use an incentive spirometer approximately 10 breaths per minute while awake. Is this true or false? Obviously, this is true. Now, if you guys, I don't want to do this now because I don't want to lose whatever, but something else to consider in terms of supplementation is a spacer. It's kind of an offshoot with regards to your handheld, you know, inhaler. And, you know, with the spacer, it really facilitates you making sure you get all that medication. And if you go online, you'll see this video that shows you the utilization. But basically, what this does is that it makes a whistling noise if you don't use it right, and it also reminds you that, you know, in between different types of inhaler therapy, that you may have to wash your mouth out, especially with steroids. Mini nebula treatment is, it basically helps to humidify, to moisturize the upper airway so that you're able to, expectorate, and it can also be another means of facilitating certain medications that will once again help to open up the airway. Now, chest physiotherapy, what I call chest pulmonary toilet, which is an old term, includes postural drainage, chest percussion, and the idea and vibration, as well as, breathing, but breathing retraining. And basically what you're looking at is with the breathing retraining, you're looking at increased efficiency of the respiratory muscles. Percussion, you want to help to improve ventilation, and the postural drainage is to help remove secretions. We now have very fancy beds that do all of this stuff, not the breathing retraining, but the idea of postural drainage and chest percussion and vibration, but it's a very simple concept. Postural drainage uses gravity. So you want to facilitate drainage by positioning the patient in a way that will have the secretions move in the direction that you want them to. Okay, so in regards to when I think of postural drainage, when I first started working many years ago, I worked on a neurology neurosurgery unit, and we were part of the Yale New Haven study at Bellevue for the spinal cord injury. And there was this one gentleman who he had jumped a turnstile and tripped, and he was a C4, C5 neck injury, so he just had his diaphragm. And I remember that at night he would fill up, but in the morning when I would put him in Trendelenburg, and I would put him on his belly and bang on his chest, he would clear up like right away. So this idea of postural drainage is something that, it's a simple concept, but is very effective in terms of managing secretions. Chest percussion and vibration, definitely you'll see that as something that you can have done on the bed. You simply press the button and the bed will percuss, as well as just vibrate. Percuss is banging. Vibration is what you think it is. So it's a more simpler, more gentle movement. And then you have these high flow the vests that can also do the same thing. Once again, home oxygen, as I mentioned to you before, there's ways of having it administered at home. And so emergency management of the upper airway is you're looking at making. Go ahead.
I'm sorry, I didn't hear anything you said in that right there.
Where?
Just now, right before I had interrupted you. I didn't.
Can you hear me now?
I can hear you now. Yeah.
Can you? Okay. Basically, emergency management of upper airway obstruction is to get rid of an obstruction, and not to sound, crazy, but I'm wondering now, where we're telling us all about, social distancing, I hope if somebody needs the Heimlich maneuver, they're getting the Heimlich maneuver. Remember, you're standing behind them, not in front of them, right? But, basically it's an obstruction of the airway by food. Now, food particles, in terms of food, very often, in terms of obstructed airway, as I've seen it, and you'll find it in the literature, is related to people when they drink alcohol, and they'll aspirate a large piece of meat, or something of that nature, consistency. And, and that'll be the source of obstruction. Somebody vomits, is there any blood clots, etc. And you'll see that by seeing it by inspection. A patient will say to you, you ask them, are you choking? Are you choking? And then they'll give you the universal sign for choking. You can palpate and auscultate with lesser obstructions, but obviously this is going to have to be dealt with. Now, in terms of adjuncts, you have oh, I messed up here. You have your endotracheal tube. All right. Let me step back a little. You have your nasopharyngeal airway. Very often they call this the nasal trumpet. And it goes into the nares, and it actually protects the nares so that, it won't cause trauma. But it also gives you a better direction if you're going to nasopharyngeally suction somebody. Okay. The oral airway, the oral pharyngeal airway, this is only used on the unconscious patient. Only used on the unconscious patient, because or somebody without a gag reflex, okay? Because if they have a gag reflex, they're going to cough this out, right? This is just going to get coughed right out. So if somebody's unconscious and their tongue is obstructing the airway, this oral pharyngeal airway will help pull the tongue back. Subsequent to that, you're looking at your endotracheal tube, which in the adult always has a balloon at the bottom of it. In children, I'm not going to profess to know anything about peds, except that I know that pediatric endotracheal tubes do not have balloons at the end of them, all right? Because they have short necks, the tube just slips right in and in essence forms a seal. But with adults, you have that balloon at the end of it, as you do with the tracheostomy tube. The thing that you have to remember about that balloon, if I don't say it again, is that there's a certain basic principle that you have to remember about tissue, okay? Capillary pressure is between 18 and 20 millimeters of mercury, okay? And 18 to 20 millimeters of mercury. And if you, I shouldn't, let me back off. It's not 18 to 20. It's, I was distracted for a minute. Sorry, scratch that. Capillary pressure is 30 millimeters of mercury. So if you more than 30 millimeters of mercury on any piece of tissue, it's gonna cause ischemia, no blood flow, death of tissue. That's the principle behind pressure ulcers, but it's also the principle behind what I want to tell you about the endotracheal tube. So if you have more than 30 millimeters of mercury pressure in that balloon pressing against the walls of the trachea, you're going to cause a decrease in blood flow. You're going to cause ischemia. Subsequently, you're going to cause a fistula or breakdown of the trachea. If you erode the trachea posteriorly, you'll erode into the esophagus. Not a good thing, but you could fix that. If you erode anterior on the anterior portion of the trachea, you're going to erode into the innominate artery, and that is almost impossible to fix. So as a result, you never want the pressure in that balloon to go greater than 30 millimeters of mercury. So a safe pressure for that balloon is to be 18 to 20 millimeters of mercury. The balloon basically is there to help stabilize the endotracheal tube. And by stabilizing the endotracheal tube, it also makes a seal so that there's little to no air exchange. So it makes it a closed system, so that ultimately when somebody's intubated, they're going to get placed on a ventilator. So the purpose of the balloon is to close off the lower airway from the upper airway so that you can have a closed system so that you can attach it to a ventilator. So usually it's respiratory that measures the balloon between 18 and 20 millimeters of mercury. Okay. Now, this is obviously a tracheostomy tube, the same deal, 18 to 20 millimeters of mercury pressure in that balloon. And then this is just the pilot that helps you, just like over here on the endotracheal tube, to give you a sense of how does that pressure feel inside the patient. And then this is a tracheostomy button when you're getting ready to discontinue those airways. Now, I put in a video online. No, I put a video in on Blackboard is what I meant to say. And that video is from the New England Journal of Medicine, and it's accurate in the sense that this is what they still do. It's accurate in its procedure. The only thing is that they mentioned something known as the Salek maneuver. And the Salek maneuver is when you press down on the trachea so that you close off, in a sense, the esophagus. So it's more likely that the tube will go down the trachea. That's really not necessarily done that much anymore. So, I mean, I'm not going to tell you it's not done, but it's very rare that it actually is done. Okay. But I would ask you to please look at that video if you haven't done so already. It's on Blackboard. And also in this diagram, you see the two types of or straight blade. Okay, curved blade or straight blade, and curved blade or straight blade. Basically, it depends upon the anatomy of the patient and also the preference of who's doing the intubation, which should be anesthesia. And here's a picture once again as to what it would look like in terms of the endotracheal tube. Endotracheal tubes for adults, the size that's used most commonly is 7.5. They'll use a slighter bigger endotracheal tube if they're thinking about bronchoscoping the patient for whatever reason, but generally it's 7.5 or an 8. And the other thing that you're going to take notice to is the marking as to how far down it goes. Now, your tracheostomy tube is placed surgically. And there's two ways that your tracheostomy tube can be placed. Excuse me. It can be placed either in an open surgical approach, which means the patient has to go to the OR, because what that means is you got to use retractors. Anytime you use retractors, you have to be in the OR, just by the by the sterile approach, at least for now. What can be done at the bedside is a percutaneous approach with a tunnel, okay? And that can be done at the bedside. But once again, you're looking at obviously, very much obviously, a sterile procedure. In terms of looking at, you're looking at the tracheostomy tube, you'll see that it has different parts to it. It has the balloon, as I mentioned earlier, 18 to 20 millimeters of mercury, but it also has an inner cannula, and that inner cannula that goes into the tracheostomy tube can either be reusable, which is what this one looks like, so it gets cleansed with peroxide and saline, or it can be disposable, which means what it sounds like. You're gonna change it every shift. Usually it's every 8 to 12 hours. Okay, and excuse me. And the obturator is basically what helps to place the tube. Now, in terms of tracheostomy strings, we really don't use strings in the truest sense anymore. What's used now is a foam backing, because those strings themselves can become problematic and can eat away in the back of somebody's neck. Okay. Okay. That's what you need. I'm going to take, I was using a different book, so I'm not sure that that's still current. In terms of management of tracheostomy, you want to obviously continually assess the patient. You want to make sure that you have a proper suctioning. The patient is semi-Fowler's. In terms of analgesia and sedatives, that's not always necessary accordingly. That's more necessary if the person's on continuous mechanical ventilation. And you always need to provide appropriate means of communication for the patient. Yeah. Okay. The daily care, you want to look at, once again, assessment. You want to make sure that, actually, this is just what you would do respiratory-wise anyway, or not even just respiratory-wise, but general assessment. You want vital signs to make sure they're within appropriate parameters. You want to make sure their blood gases are okay, fluid and electrolytes are okay, and you're going to listen to their lung sounds and take note to their And remember that if they have a color, if secretions have a color, that generally means infection. If they're clear, or white, there's generally not an infection. Okay. Suctioning, there's two types of suctioning. There's either open or closed. Here it's open. And it's once again, remember that all suction catheters are single use. You don't reuse anything, all right? You throw it out. And if you see that somebody has put a suction catheter and left it in a bottle of sterile water or saline, just throw the whole thing out and start anew, because suction catheters are single use only in an open system. Now, a closed system is this, and this is what you see when somebody's on a ventilator. So this catheter stays in place because it's closed for about 24 hours, and basically gets changed on a daily basis. And subsequently, you're looking at it being hooked into the the circuit, the ventilator circuit. So here's the tubing that goes to the ventilator, and here's the closed system accordingly, and the suction. We don't do saline lavage anymore. It's not recommended. So basically you just suction. Remember, you always suction pulling out, not going in, and it's a sterile procedure. In terms of daily care of the stoma, you need, once again, you need to look at what you're going to do for the inner cannula. And if it's disposable, you just replace it. But if it's not disposable and reusable, that's when you're going to use the hydrogen peroxide accordingly. And the holder, in terms of the ties, is what I said, it's going to be foam backing. not literally, the umbilical tape as in the past. So generally speaking, you're gonna change the inner cannula every 12 hours, and then with non-disposable, you're gonna clean that inner cannula and change it in the sense that you're changing the inner cannula accordingly to be cleaned. Decannulation, if you see the button, then the cuff needs to be down. Sorry. If they have a button in there, the trachea cuff has to be down. It means it has to be deflated, because if you left it inflated and you put the button in, you're going to suffocate the patient. So the idea is that whenever you see that button, the tracheostomy cuff needs to be down. Anybody with an airway issue, you want to make sure that you're looking at and specifically surrounding decannulation, you want to make sure that you're not setting them up for aspiration. So these patients may be on enteral feedings, and you're just monitoring. You're monitoring their ability to swallow and their gag. Speech therapists are the ones who actually do the swallow tests. So in the daily care of somebody who has a tracheostomy, in most institutions, you're going to see a sign at the head of the bed. You're going to have an ambu bag at the bedside with a face mask. You're going to make sure that the ambu bag is hooked up to wall oxygen. If somebody has a metal trach, which you rarely see, but every time I say that, somebody shows up with one, you just simply have an adapter to attach to the bag, and so that you can place it in the metal trach if you need to ambu them. You're also going to have a tracheostomy set at the bedside it's the same size as the one in use, and then you'll have a spare and a cannula as the same one in use. But remember that if a tracheostomy comes out, you don't put it back in. All right, you have to call the primary care provider, and then you'll ambu the patient with the face mask accordingly. Because you can do more damage, what you're doing with putting the trach in than by leaving it out. And then, it's important to always have a communication board for these tracheostomy patients to make sure that, they can communicate with you accordingly. Now, I'm going to start with mechanical ventilation, and then I'm going to stop at a certain point and let you guys go for the night. All right. Now, obviously, you need to have an artificial airway in place in order to have mechanical ventilation. All right. And primary needs for mechanical ventilation are that the person can't ventilate properly, and that's reflected by their blood gases. Also, they have poor lung expansion. Now, sometimes, blood gases may say to you, oh, we don't need to intubate. We don't need to intubate that patient. But, but the patient is showing you great fatigue or breathing. So you need to look at the total picture of the patient. Postoperative prophylaxis, an example of that would be post-op open heart. If they did a sternotomy, they want to make sure that that those bones heal. So they want the patient to stay sedated, not moving, for at least 8 to 10 hours after they're intubated. Maybe post-injury to exercise. Flail test is when you have free-floating ribs, that you've broken ribs. And obviously, if you're apneic. And, then, if you have reduced drive to breathe because of overdose or, stroke, neuromuscular issues, or musculoskeletal issues, or upper airway obstruction. In terms of clinical, some they don't have a good negative inspiratory force. It's less than 25. Their vital capacity or their minute volume ventilation is no good, and their blood gases are no good. So the goal of mechanical ventilation is basically to increase alveolar ventilation. It's almost redundant what I'm saying. Help with oxygenation, and to decrease the work of breathing, subsequently decreasing your metabolic rate, so that ultimately you have cellular utilization that is a normal need, not an expansive need. As you know, spontaneous breathing works by negative pressure, all right? And that negative pressure gradient allows for airflow to go into the lungs. It also helps to facilitate venous return. So you're looking at two systems that are in that thoracic cavity that sometimes we have a sense of separating in terms of function, but bottom line is that they work together. So that negative pressure obviously will help to bring in the gas, but will also help to bring the venous return back to the heart. And basically this guy is looking at both gas and the blood volume together, so that you could have a good ventilation perfusion ratio 1-to-1, as we mentioned before. Now, the work of breathing, what does that mean? You'll hear them talk about that all the time in the ICUs, and when somebody has a facility, a chest, a lung issue. So the idea of the work of breathing, compliance is how well does the lungs accommodate volume. Elastance is how well it does that recoil, and then resistance deals with the size of the airway. So if you have good stretchability and you have an adequate airway, subsequently you hold on. Sorry. So you have a decreased compliance, and elastance tells you that the lung tissue can stretch and can recoil. Resistance tells you that your bronchus is of an adequate size so that gas doesn't have a problem going in and out. And if there's any interference with any of those three things, you're going to increase your work of breathing, and that's going to increase the metabolic profile for the patient and ultimately lead to bad outcomes. Now, there's two types of ventilators. The two types of ventilators are negative and positive. So let's look at the oldest one first, which is the negative pressure ventilators. And negative pressure ventilators are what they call the old iron lung, all right? And that you saw with polio patients. And to be really honest with you, at the beginning of when I started working as a nurse, I used to see, they used to call them the drinkers because that was the company's name. But I used to see iron lungs But interestingly enough, I saw them for sleep apnea patients and and they used to have those patients on a one-to-one because the only thing that was outside of the machine was their head, and you needed to meet their other needs. The thing, though, with negative pressure ventilation is that it mimics spontaneous ventilation because it's negative pressure applied to the wall of the chest, so it facilitates that gas flow. There's no need for an artificial airway, and like I said before, it was used primarily for people with neuromuscular disease, so that polio victims, but other individuals of that nature with neuromuscular problems also used it as well. They have less restrictive devices that can do that, primarily the Pulmorap and the chest caress, which you see in the diagram in the lower right-hand corner. Is positive pressure ventilators and positive pressure ventilation. And this is the ventilator that we're talking about that needs to be brought into the hospitals in this crisis, okay? In regards to positive pressure is what you're going to send through an endotracheal tube or a tracheostomy tube. And it sends gas into the lungs so that it does so under positive pressure, so that it increases that intrathoracic pressure, it increases that pressure throw, that pressure flow into the lungs. And it actually, in essence, is the opposite of spontaneous breathing. So if you have spontaneous pressure in the thoracic cavity, it's going to potentially decrease venous return, but it also may cause damage in terms of to the lung tissue itself. But ultimately, what the positive pressure device does, of its benefit, outweighs the negative components as well. In terms of, there may also be something known as a ventilation perfusion mismatch, because, I always tell people we have to take this, but, where physics comes into play, that gas is going to follow the path of least resistance. So that gas is going to, necessarily go to the areas that we need to go. So that's why there's settings on the ventilator that ultimately will help to prevent this ventilation perfusion mismatch. Okay.
Professor, can you repeat the ventilation and perfusion mismatch? The whole thing was kind of blurred out.
Oh, I'm sorry. Basically, gas goes, the principle you have to remember is that gas goes the path of least resistance. So when it's pushing the gas in initially, it's going to go to the, I hate to say good lung, but that's where it's going to go. All right. And subsequently, there may be a ventilation perfusion mismatch because of that. So there's settings on the ventilator that help to prevent that from happening. Okay.
So,
I think I'm going to, go ahead.
If I'm understanding correctly, the ventilation mismatch is that the air is actually forcing into the good lung, but it's not affecting the lung that we need it to affect, and that's
Right.
where the mismatch is.
Right. I think I'm going to stop here because I think it's getting late now, and I just wanted to bring up, ultimately, negative pressure. Somebody's asking me, so negative pressure would help both the good and bad lung. In essence, yes, but the deal there is that you don't have as sophisticated modalities to help the patient ventilate. It's only going to provide negative pressure to facilitate the gas going into the lungs. So if you if you're on a negative device like an iron lung, it is going to help you mechanically, but it's not externally, but it's not going to help you internally. Okay. I'm going to give you some more information next time we meet, and on the ventilator, and not all of it will, I'll let you know when I'm going to test you on more directly, but I think it's important that you have an understanding about ventilators, because remember that if a piece of equipment is left by the patient and nobody's standing there by the patient to manage it except you, then you got to know something about it. So, when a patient's getting hemodialysis, the hemodialysis some term later. And we'll go over this when we talk again, when we meet again on Thursday. All right.
Okay.
Now
Yeah,
I have to bring up some issues for you guys. Sorry, go ahead.
I just didn't hear that last sentence you said about what you said right before you said, and that's what we're going to go over this coming Thursday.
We're going to finish up the ventilator assessment.
Okay.
And somebody raised their hand. I'm sorry. Here. I don't. What? I can't seem to get you. Getry, did you want to say something? Do you have a question?
Guys, at this point, if you want to ask a question, go ahead and unmute to ask.
Yeah, I got you. You're muted still.
Okay.
Yep. Hi, Professor.
All right. Go ahead.
Right. I just wanted to try out the raise hand function to see if we could use this to ask question if you're seeing it at the same time, so that everybody can get a chance to ask questions.
Okay. All right. I mean, if anybody has questions, just interrupt me as we're speaking. But I tried to click onto it and it just didn't seem to open up. I thought I had opened it up, but all right. I'll double check that. The issue is that I just got an email that, I forget. I mean, it's like Thursday we'll have, but Friday was supposed to be off from school. Do you guys still want to have lecture on Friday?
Yes.
I mean,
Yes, absolutely. Does
Yeah.
anybody oppose that?
That's okay by me.
I don't oppose it, but if it can be recorded somehow, because like I said, what's what I wanted to text you about. My work schedule is going to change, and I might be switched to Friday. I'm going to be switched to Fridays for this.
Okay.
For however long this lasts.
Question for Friday's lecture. What time would it be? Because I would be at work at that time from like 1 p.m. I most likely would be on my way home. What time would the lecture start?
It would probably be at 1 p.m. the normal time, right?
Right, but
Regular class time, we can record for who's missing it.
All right.
right. All right, we'll do that. And then the following week is basically vacation week, unless you guys want to go through that as well. It's up to you.
Why is
I don't
next
have a
week
problem.
vacation week?
I mean,
sorry?
I'm totally fine having lectures all the way through so long as everybody else is.
I'm okay with that.
Same.
Because I mean, we did just kind of have a week off anyway.
Yes.
I'm fine
What
with that
is
as well. I
vacation week?
start studying one way or another, so I need to learn whatever we have to learn.
Okay, so we won't. Well, I won't do another Tuesday, but I'll keep doing Thursday and Friday, and if we need to, I'll pick up another Tuesday. Okay.
That
sounds
sounds
That
good.
would
That
be
sounds good.
fantastic. Thank you.
Sounds great.
All right, and you guys, even though like I see you have office hours on Thursdays, just text me or just text me. This email stuff is, anyway, I'll leave it alone. Just text me any questions, okay?
Yeah, it's an adjustment
And
for all of us.
yeah, and then no, I didn't I mean, I couldn't figure it out. My email at BMCC was, well, actually, I don't want to, I'm going offline the topic, but somehow they still have me going to Hunter, and I went to Hunter as a student, you know, in 1974 to 1978, and you know, somehow they still have me with certain, you know, stuff from back then. So I,
Right.
you know, so it gets messed up. So, but we all will. That's nothing. We'll all live through that. All right. So we'll just keep going, and when we finish a topic, I'll give a review, and then I'm going to put I guess a test exam, meaning just to see if it works. Not, you know, not with any questions make any sense. That guys, and you all don't have to get on. I just want to see if it works. Right? But other than that is, and then you know,
No, I didn't. We did not hear. We're not hearing anything you're saying.
She says she's gonna post a.
Can you hear me now? Can you hear me now? Can you hear me now?
Yes.
That's
Yes.
better.
Yeah. No, I just said I'll send you. I'll put up these slides, and then I'll put up these slides, and then I'll also send you what the state board SED is saying, and then I'll also put what else do I owe you?
I mean, slides we have on a book, so I don't know if anybody needs slides still?
No,
No, okay.
because we
I guess
everything
I'm
the
just-
workbook.
Yeah, I'm gonna. What I'm gonna do.
You don't have to upload it again. We can separate it if we need it.
Okay, and then